between our compassion and our sense of economic leadership in the world. And that's what's driving this.
You know, as I sat here today and listened to all of these really informed panels and really smart people, I kept asking myself, how have we gotten ourselves to a place where Medicare can't negotiate with the drug companies for lower prices, but the Veterans Administration can? Now, that seems obvious to me that there's something wrong here, but I guess it'd be very difficult to get undone. How did it get there, Congressman Dean?
Well, I would just say that's a great example. It's a great example of a debate between what role you want government to play in the life.
So I think that, you know, it's not there specifically, but I mean, I think Mike is right. But it got there specifically because Congress inserted that language in the law, that Medicare would be basically prohibited from negotiating. And that has been,
how did that happen?
It happened in 2003 with well, it happened with the Part D plan. When Part D was decided to be added to Medicare with private sector players, that language was inserted, and it wasn't just that time. It's been proposed over and over again to get rid of it, and the majority of Congress has refused to get rid of it. And I will tell you, Bob, in 2010, President Obama was very eager to put drug pricing regulation into the Affordable Care Act. And there were not enough Democrats who would have supported the Affordable Care Act with drug pricing regulation in it. He asked for that permission in every budget that we submitted, I'm sure through Sylvia's days, but I know every time I went to the Hill, we asked for the authority. Congress wouldn't have passed it. But I think now we would have a different conversation. If we could get it proposed in Congress, my guess is it would pass. But 9 years ago, it wouldn't.
You know, what's interesting about that, by the way, private plans can negotiate, but since they don't have enough people, then they don't have the leverage and the power. But I want to go back to something that I sound like a broken record. I said it earlier this morning. Do you know why the pre-existing condition is not acceptable? Because you say it's unacceptable.
That's right.
You can't be a member of Congress, a United States Senator, and go to some town hall and stand up and defend. Well, if you've got a pre-existing condition, tough. So the public has driven this. And I tell you where I think the public is going to drive this whole issue of pharmaceutical pricing. And they're going to say, why are they paying X amount in France, but we're paying so much more here? And a big chunk of that is because we cover all the costs of producing the drug, and what they sell overseas is like icing on the cake. But at some point, people are going to say, enough of this. Now, here's really a question that I like these two, they're brilliant people, to answer. If I'm in a business, and I know the price of steel is going up, I find another supplier. But if the price of healthcare is going up at 10%, how come I don't tell my plans, give me a better price based on quality, make my people happy and save me money? Because they could be an enormous cost drop, an enormous change agent, right, in healthcare, the private sector. Why aren't they raising Cain?
Well, I think is that if they were here, they would argue, well, that's actually what's happening with the PBMs. We're lumping all of that together and we're negotiating with the PBM. And you can decide the rationality of that on your own. But could I just say that without taking a position on the issue, this business of having the government negotiate drugs is not without a rational two-sided argument. The only way you can use the government to negotiate drugs, I've done this before, I know, what you have to say is, look, if you don't drive your price down, your drug is off the formulary. And at that point in time, you now have government deciding what a patient can get and what they can't get. And so it becomes a question of having the government choose instead of people choosing. And again, you can decide.
Well, I mean, I take your point on that, but on the one hand, you're saying we'll let the Veterans Administration do it, but we're not gonna let the Medicare people do it.
Well, that was because Medicare Veterans is a system that basically assumes their risk. And I'm not here to defend that. I'm just saying I think that's how it happens. There's a difference between a healthcare system and then meaning veterans as a corpus assuming risk, and then the broader economy. I think those are two different, and I'm not here to defend it, but I think they're different.
But I think that's where we need to get, is to have this substantive conversation. If what we think are the downsides of negotiating and having the government negotiate price, how do we want to deal with potential downsides? Can you get to the place where you can have the conversation to create the construct to minimize the risk that you articulated? Can you do it in ways where you model? I mean, the proposals that Kathleen mentioned, we actually were starting with pilots so that you could try it with limited groups of drugs and see how it worked and what would happen. And so I think what we need to do is get to the place where, okay, let's have the conversation. Do we think we want, as a nation, which are we going to pick? Are we going to pick increasing drug costs or that potential risk? And I think that's why Mike was saying it is about these choices. But the problem today is we haven't gotten to the substantive conversation. We use, they just become words. So Obamacare becomes a word, not the substance of what it is, or each of these things. And so the more we can drive to the substantive conversation of the specifics, I think the more quickly we can travel on the journey that you described.
I think the big lie in anything, in all of this, is that somehow we're going to solve this with policy alone. The reality is this will only be solved when we have a lot of people convening on separate problems to be able to squeeze the waste out of it and align the incentives. Once we have done it, it can't be just policy. It really does have to be a million little things that ultimately is driven by the policy.
Absolutely.
So why are drug prices so high?
I'm sure he was asking you.
I think it gets to, again, what we've been saying, the question of paying for value and paying for what something is doing. And usually when markets work, supply and demand, and that's, what sets price. And one of the things in our system and the way our system is worked, it's not a transparent market. That's why some transparency things can help some, but they don't completely solve the problem. But I think moving healthcare to a place where it's a market, where people see, they understand what pricing is, they understand how it's priced, they understand what they're going to pay, and they understand the value, and we can quantify that and talk about it. That's when we'll get to the place where we can have the kind of pressure.
Look, we took on the PBM. We were the first state to actually do this. And nobody can explain how. Maybe Mike can, but we have no clue how the PBMs work, what their margins are, where their profits are, what do they get, what do the companies get. Total transparency is what we imposed in Ohio right at the end before I left. That transparency is going to say a lot of things about where these prices are. But my understanding of this is when the companies do their R&D, and we ought to find out how much our colleges do and how much is NIH doing and all that. When you look at all that, though, they charge their prices here, and people say, well, why do they charge so little other places? It's because other places, it's just icing on the cake. They've already made their money back, and now the opportunity, it's sort of like, the old elasticity theory of going to a theater. If you fill the theater, every other ticket is just on the top profit. And I think this is not going to last forever. I have to tell you, I have not said this before. I got a call from President Obama when he was president-elect, and I didn't go to Trump Tower, but I went to the White House and I sat with him and we talked about health care. And the one thing I told him is prescription drugs is something you have to deal with. When I'm listening to Mike, and I think there's a good point that he makes about how do you negotiate as government, but I can tell you on my Medicaid operation in Ohio, if we had the ability to exclude certain high-priced drugs from our formulary, I'm going to tell you what would happen. Their price would come down. And I'm in favor of their price coming down. One final thing. We don't want to demonize the pharmaceutical industry, Bob, because if you've got schizophrenia or if you've got Alzheimer's, we need these people to produce these things. But as one of my friends once told me, pigs get fat and hogs get slaughtered. And the industry have to consider where they are, because they've had so much political power for so long, and I have to tell you, it's going to come to an end. And they may end up with something that they're really going to regret, that they didn't get out in front of this thing. And I'll give you one simple. Why the heck are the rebates not going like we did in Medicaid? Why aren't you going to the Medicare patients? I don't even understand it. It's ridiculous. Come out with a series of things that you can do. That's what I think.
We're coming to the close here, I see by the clock. Do you all agree with that? Do you think that the prices may actually come down?
Unless you think it's my turn. Yeah. Listen, I think that, just to address the correlation and answer specifically, this is there's probably 100 different categories that we could go down and answer that question in totality. A part of it is what John has said, part of it is what Sylvia suggested. What hasn't been raised is that we have this appetite for safety and assurance in the safety of our drugs. And so we hold them to a very high standard. What John has said about the Europeans taking advantage of that is absolutely true. That's a trade problem, and we ought to solve it. But ultimately, I think the drug companies are going to have to do it. They're going to have to choose between moving to a government pricing decision and finding ways to begin to be paid on the basis of what works and what provides value. Those are their two choices, because they can't sustain where they are. And I think over time they will choose to look for more value, and I think the government will likely get a little more involved in it as well. We can't sustain what we have. I think drug prices will come down.
That's right.
So
I would just add, I think it is, to answer your question, yes, change will occur. Exactly what it will look like, I think it probably is some combination of things, but I do believe 5 years from now, there will have been changes, and changes that put downward pressure on price increases. And I think that's the other thing that we have to remember. Moving from the level of inflation that we have in these to lower levels of the price increases will be the first step, but I think it will happen.
I think the first step's already happened, and that was the previous panel talking about Civica with generic drugs and being able to step in and begin to drive prices that way. That's the beginning of the trend that we're talking about.
I'll just close with this thought. When I interviewed Gary West out in San Diego, he didn't hesitate when I said what needs to be done. He said allow Medicare to negotiate drug prices. We need to get value-based fees and transparency. And when I asked him the question I just asked you, what do you see ahead? He said he really didn't know, because he said until we get cost in hand, there's really no way to know. Thank you all very much. Thank you.
And now for some final thoughts from Gary West.